Right. Good afternoon, everyone. Good morning, good evening, wherever you are joining us today. My name is Adrian Wong. I'm a consultant at King's College Hospital in London Critical Care, and it is my absolute pleasure and honor to spend the next 30 minutes talking to Professor Glenn Hernández. Well, Professor Hernández is a full professor in the University of Santiago in Chile. He is the coordinator of the Latin America Intensive Care Networks, and he is the principal investigator for the ANDROMEDA-SHOCK studies. Welcome, Glenn.
Hi, good morning. Thank you for this invitation. Thank you very much.
Fantastic. It's like I said, I'm really looking forward to this. So let's kick off then. Full disclosures, the Andromeda trial is one of my favorite critical care trials of all times. So can you summarize the trial for us and how it has changed your practice?
Yeah. We were working with peripheral perfusion for almost 10 years already. And we use it as a trigger, as a target for septic shock resuscitation. And because there were a lot of background studies, epidemiological studies, showing that if you have a normal peripheral perfusion after resuscitation, you can stop resuscitation more faster, quickly, and you have better outcomes. So at the end, and we were also, along the years, we became more and more troubled with lactate, because lactate, we know now very clearly that lactate has many sources, and not all of the cases of persistent hyperlactatemia are related to hypoxia or hypoperfusion. So if you use lactate as a target, it will increase the chances that you get a fluid overload or the toxicity of over-resuscitation. So this is why at the end, we launched this Andromeda trial where we have compared two strategies, two targets, normal capillary refill time or lactate normalization or clearance. And I like it very much because, capillary refill time can be standardized. A very simple, universally available technique. It's a bedside technique. And then we demonstrated, as you know, the study showed at the end, 8.5 decrease in absolute mortality, which almost reached classic statistical significance, but the world considered it a positive trial because there are very few studies, to the best of my knowledge, that has such a strong difference, 8.5. I mean, I remember the ARSNet study, you remember. So, and then— Are
you surprised? You sound surprised.
Yeah, and also, the patients in the CRT group had less organ dysfunction, resolved the organ dysfunction more rapidly, and also they got less intervention. And this is important because it was part of the hypothesis that because capillary refill time and peripheral perfusion in general is a very flow-sensitive variable. When I say flow-sensitive, it means that if you increase systemic blood flow or cardiac output or perfusion pressure, it normalizes very fast in the patient that, of course, are going to survive, the patient that have hemodynamic coherence, et cetera, it normalizes very fast. We have seen patients when you give just a fluid challenge, you increase a little bit, and then peripheral perfusion normalizes. It's the key for me is that it represents the ischemia reperfusion process. When you see normalization of the skin, you are a witness of reperfusion, and this is very important. Of course, you can say, maybe who cares about the skin, no? Who cares? I mean, but it represents physiologically the neurohumoral response to shock, to shock. So when you increase systemic blood flow, the adrenergic tone decreases, and these simultaneous processes lead to a reperfusion of the skin. And there are very interesting studies, one from Brunauer and also from our group and others, that demonstrate that there is a sort of correlation between the reperfusion of the skin and the reperfusion of more important organs, such as the hepatosplenic region. Because this is logical, because they share the same neurohumoral response that gets flow away from these territories. So in this sense, it's very, very interesting. And the most important thing from my point of view, that it can be spread very rapidly to the medical community. It can be applied from the Mayo Clinic and the sub-Saharan countries, I mean, everywhere, because you just need to touch the patient.
I mean, I completely agree with you. I think one of the reasons why I enjoy your study so much is the sheer simplicity of your study. Now, Glenn, given the fact that you've already said that you were already using capillary refill time as part of your practice in your department, how did the trial actually change any of your practice? Were you using perhaps less lactate more, or you were less bothered about lactate? Has it changed your practice?
I think that we assess lactate less frequently now, much less frequently. I think it's an important variable because, well, of course, it's part of the definition of the actual septic 3 definition of septic shock, of course. But besides that, it's an important variable because it gives you confidence. If lactate decreases, it's always good news. I mean, as a prognostic signal. And for example, if you start with the lactate and you confirm that at least by the definition you have a septic shock case, and then you measure again at 6 hours and you see that lactate is decreasing, then you are more confident that you are going in the right direction, And in the inverse, if lactate is increasing, this is bad news. Maybe it's not only about the persistent or worsening shock, but it may represent other issues. For example, an uncontrolled source of infection, necrotic tissue, extreme hyperadrenergia, always bad news. So for me, it gives you a general signal on you are going in the right or in the bad direction, and alert, a warning signal for complications maybe. But I wouldn't die if I have no lactate. So I wouldn't give my life for having lactate. But if I have it, I would measure it just, let's say, every 6 hours, something like that, just to have this. Mm-hmm. Okay.
So you're measuring lactate less and less then?
Yes.
Okay. Right. I want to pick up on another element of your answer and discussion earlier, and you talked about flows. So I think in general, hemodynamic management in the intensive care setting has moved away from sort of pressure-based resuscitation onto flow resuscitation. So on that note, do you use any form of cardiac output monitor? And if so, is that the cardiac output monitor of your choice if you had to redesign intensive care?
Yeah. When I was young, a lot of years ago, it was the time of the pulmonary artery catheter. It was the king, I was so proud when I put myself a pulmonary artery catheter. I always tell residents now that in one night shift, I put 4. It was, so I felt like a hero, But at that time, you are too young, but there were some studies that demonstrated that if you put a Swan-Ganz catheter, you with this information, you would change the direction of the treatment radically in almost 20-30% of the patient. You were giving fluids? No, stop fluids, give diuretics. This was the studies at that time. I would say nowadays, with the availability of echo, it is very, very, very infrequent that you put a Pico or a Swan-Ganz catheter and a surprise. It's when you put the catheter, you know what you are going to find. It's a sort of I would just put this continuous cardiac output as monitors just for the more complex patients. for patients we have a simultaneous ARDS and septic shock, because then you can get lost. In patients that do not respond to early resuscitation, and you see they are getting worse and worse. And I always tell my residents also that I would put a continuous cardiac output monitor if I have to, let's say, start a second vasoactive drug. If you are only with norepinephrine, it's simple. You know what norepinephrine does, you know, in the preload, the heart, the after, blah, blah, blah. You can almost guess with clinical signs. But if you put vasopressin, you add vasopressin, or you are thinking in starting epinephrine, and because the patient is getting worse, then I think you should. Because sometimes when you add a second drug, the cardiac function, the cardiac output can change unpredictably. I mean, sometimes when you add vasopressin, some patients, stroke volume decreases, and you have to see this. And to the best of my knowledge, there is no continuous, I mean, in clinical practice, transthoracic, at least continuous echo. So you should control echo every, but so in the more complex patient, I would definitively put these catheters, not because they are going to change dramatically the direction of the treatment, but because especially to detect unwanted side effects of what you are doing. Because if you add a second drug and you see a decrease in cardiac output, then you are doing very bad. I mean, so you can adapt, you know. But I think that this is necessary in our experience in less than 30% of the patients. Most of the patients, I mean, at least half, 60 maybe, they respond to initial resuscitation very nicely in general, and you can, I hope that we can demonstrate in the ANDROMEDA-2 study, looking at the signals of the monitor, the basic monitor, especially the pulse pressure. The pulse pressure is a very, very physiologically sound and nice surrogate of stroke volume. I mean, for example, you have a patient with a hypotensive patient, 80, 60 to 60. It's totally different as a patient with 80 to 30. 80 to 60, this patient has almost no stroke volume. Either he has an extreme low preload, or he has a cardiac condition, a very severe one if you have a stroke volume of 20, I mean, a pulse pressure of 20. So looking at the pulse pressure, when they call me in my ICU, I look from the far side, I see the monitor, I see 80, 60. No, it's a problem. So do an echo, assess the preload, blah, 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 blah. But if you see a hypotensive patient with 80 to 30, this is septic shock unless proven otherwise, because you have no tone. And then this, you know, there is a lot of studies going on about the early use of vasopressor, blah, blah, blah. And this also has I think it contributes because the vasoplegia is not solved with volume, because, you know, the monkey reflex is to push fluid, because he has hypotension, but he has a diastolic blood pressure, a neglected signal. Who cares about? I mean, it's so important. If you have a low diastolic blood pressure, this is very important news for the patient, for management, or no? Do you agree with that? I mean,
well, I'm going to pick up a lot of elements of what you've said, Glenn. But if any of our viewers have any questions or comments, etc., just feel free to send them in. I'll do my best to get through them. But let's pick up a couple of elements from what you've said. So echocardiography, you've mentioned, and you would use a continuous cardiac output monitor, in your case, the PA catheter in the sicker group of patients. But one of the questions I've often been asked, especially in the way how hemodynamic management is being developed in intensive care practices, when you look at all these numbers, ultimately they are macrocirculatory numbers. Macrocirculatory. Yeah. What's your thought on the microcirculation and whether we should be looking at that more closely?
I totally agree, Adrian, with that. There are two things. For example, when you look at the heart, for example, you look at fluid responsiveness, preload dependence, you're looking at the heart. you are trying to figure out in which part of the Stalin curve the patient is, no? I mean, when you look at fluid responsiveness. But people think that this is the signal to give fluids, and oh, it's fluid responsive, we give fluids. But the big mistake is that you have to look at the other side, the microcirculation, the periphery, because what you do with the macrocirculation has to be, should be, must be a function to improve tissue perfusion. I mean, who cares about the cardiac output of 2, 3, 4 if you have normal perfusion? And then the point is, which are the surrogates, the signals, the variables that tell you if the tissues are perfused or not? You know that unfortunately, there is no, let's say, universal, unequivocal sign that tells you about the oxygen status of the cells, of the tissues. It's all are indirect, all are surrogates.
All are surrogates, I agree.
All are surrogates. So which is the best surrogate about the microcirculation? In my opinion, it's biased, of course. I think that peripheral perfusion is close to the microcirculation because we have worked with the microcirculatory, the SDF devices to assess the microcirculation under the tongue, in our case for almost 15 years. But it will never, ever go to clinical practice. In my opinion, it will always be constrained in the research area, no? So you have to look for surrogates. I mean, this is, but you have to make the mental link. Oh, I will act over the macro, but for the sake of the micro, you know, you have to do this link in your mind and then act accordingly, you know. This is, if you know that, you will treat your patients better, and you will move them away from the risk of over-resuscitation, fluid overload, you know. This is the point.
Okay, so I'm going to pick up on that because I think it's an area to think. So over-resuscitation and the issue around de-resuscitation, decongestion. There's a lot of talk about the whole concept, and then conceptually, again, it makes sense. But the evidence is really not there yet. Your thoughts on the whole concept on de-resuscitation, decongestion? Should we be doing more of it? Should we be looking out for it more in our patients? What should we be doing?
I think if you provide a more physiological resuscitation, if you select the right targets, if you identify the clinical phenotypes, at least you know which patient you have to treat with fluids, in which you should use early vasopressors, blah, blah, blah. This is the issue of ANDROMEDA-2, you know, the next study. If you provide a more rational resuscitation, you will not move your patient to the status of fluid overload in general. But sometimes you receive patients in your unit that are transferred from other places or that have been subjected to over-resuscitation in the OR, in the emergency department occasionally, and then your decision is to de-resuscitate. I mean, this is I think I agree with you, Adrian, that we need a lot of work on that, you know, because in general, when you have a big problem, a fluid overload really, and you have a pulmonary edema, and the patient is approaching weaning, and then you should get rid of these fluids in the lung, and you can now assess this very easily with echo, with other devices, you know. Should you de-resuscitate before weaning? I mean, this is we are working on this also in some physiological studies. And then to take the decision to use diuretics or call the nephrologist and perform an ultrafiltration, this is a nice, a complex decision sometimes. I can tell you that I am very critical about also the overuse of diuretics, the overuse of furosemide, because it's people use it very liberally, you know, and it's a toxic drug. If you don't use it with care, you can, of course, you can move the patient to severe electrolyte disturbances, hypernatremia, hypokalemia, alkalosis, and it's a toxic drug. You have to use it very carefully, and of course, some aggressive de-resuscitation practices can induce hypoperfusion, paradoxically. Also. So this is a matter of discussion. For example, we follow the work from Jean-Louis de Bull, and when we have some degree of fluid overload, we try to get rid very carefully of it. But when we approach the weaning process, when we approach the spontaneous breathing trial, we always look, you know what we look? We look at the fluid responsiveness, because if the patient is in the flat part of the Stalling tube and you take out the positive pressure ventilation, you can easily induce a weaning-induced pulmonary edema. So we always try, we feel more comfortable when the patient is in the step part of the Stalling tube, you know? So this, even we are doing a study where this is a target. I mean, before weaning compared to a control group, a physiological study, we try to put the patients in the step part of the Stalling tube as being fluid responsive. And this is better because even if you take out the positive pressure, then the venous return can increase, and even you can increase the stroke volume. So it's a matter of looking at the heart. Yeah.
Physiology in action. Yeah. Now, I know you're dying to tell us. Tell us about the ANDROMEDA-2 trial that you have planned.
Yeah. Well, it's a very amazing, fascinating study for us. It's a worldwide study. It will be performing 90 ICUs, one of the biggest trials in terms of centers, in 4 continents, from the US and North America, Western Europe, Latin America, and Asia. This is very nice, Adrian, because it will represent different cultures, different public university hospitals, different, even some low-income countries included. So I think this is fantastic. And it will recruit 1,500 patients. And the idea is to compare a strategy targeting CRT, but based on hemodynamic phenotypes that you can read at the monitor, you know, to intervention strategy for 6 hours compared to usual care. And what is this? The hypothesis is based in 4 things that will be applied. First, selecting CRT as a target. This is very important because since CRT is not part of the septic shock definition, you know, in ANDROMEDA-1, 1 in 4 patients, 1 in 4, had normal CRT at baseline. They had lactate, but they had normal CRT. This means, in my opinion, that this lactate in the definition was not hypoxia related because they were septic shock, they required norepinephrine, they had lactate, but they had normal CRT. And this patient received no further resuscitation for the 8 hours of intervention. The same we will do in ANDROMEDA-2. Second, we will apply a personalized algorithm, starting with things that you can look at the monitor, as I said before, the pulse pressure. If the pulse pressure is low, you go to the fluid section, for the algorithm. If the pulse pressure is normal, you look at the diastolic blood pressure. If it is below 50, you go to adjust the norepinephrine and try to raise vascular tone. This initial individualization is new. No study in septic shock at least has applied this so easily. Achieved or signs that you can read in the monitor. Third, we will assess fluid responsiveness before and after every fluid challenge. This is you have to work to do this. You have to be at the bedside to do blah blah blah. But it's important because in ANDROMEDA-1, when we did the same, we assessed fluid responsiveness at baseline and after the fluid challenges. 1 in 4 patients, again, that just were admitted to the protocol, they came from the emergency department, most of them. They had received the 30 mL per kilo fluid. And 1 in 4 were already fluid unresponsive. fluid unresponsive after receiving this initial fluid loading. And in this patient, the algorithm in ANDROMEDA-1 directed this patient to the vasopressor test or inodilators. And at the end, when we performed the post-hoc analysis of this aspect, they achieved the same amount of goals, the targets. I mean, and they had the same mortality, but they saved 1,500 ml of fluids, unnecessary and probably harmful fluids. And the fourth aspect is to apply echo if this first tier intervention do not resolve the problem. We will perform an echo there to start the tier 2 intervention, which are a little bit more complex, but especially to rule out severe left ventricular dysfunction and right ventricular failure. So this is the algorithm. I think it is not to save fluids. We think that as a consequence of these physiological strategies, at the end, you will give fluids more rationally, and you will, because of this, avoid fluid overload and probably get less organ dysfunction, etc. This is the hypothesis, and we will compare with usual care. So this is the basis of ANDROMEDA-2.
I mean, I'm full disclosures, I'm very, very excited about ANDROMEDA-2, and I look forward to seeing the results of ANDROMEDA-2. A couple of minutes left, but I want to ask you, when it comes to sort of hemodynamic fluid trials, there's often this conflict between protocolized care, following a protocol, you see this number, you will do this, you see that number, you will do that, or consider this, etc., versus personalizing it to the patient, this whole protocolized versus personalized treatment plans. Your thoughts, Glenn?
Yeah, I mean, for me, it's a mixture of the two. I mean, I strongly believe, and we will try to demonstrate this, the usefulness of personalizing care based on signals that you can easily read at the bedside. But you have to have a background protocol that orders the intervention according to these signals. A mixture of trying to look at signals that in which you can recognize hypoperfusion or hemodynamic phenotypes, but ordering the interventions according to this. It's a mixture, I think, of the two. Protocols that are not physiologically sound. I remember, the reverse protocol, for example, raising the CVP to 8 to 12. I mean, you can do harm if you have a wrong protocol. It has no rationality, no? But if you have a protocol that I think it's useful at the bedside.
Okay, so my last question to you, Glenn. You've done all this work now on resuscitation, shock, all sorts. What is the biggest fallacy in shock resuscitation that you want, or the biggest unanswered questions in shock resuscitation that you would like to tackle, challenge, and perhaps even provide an answer?
I think that there is a confusion in the nomenclature. I mean, you should speak about acute circulatory dysfunction. When you have a low vascular tone, when you need fluids, you need vasopressor, this is a circulatory dysfunction. It is very common in the post-operative status of major surgery, Whipple, liver transplant, to have a little hypotension, requirement of vasopressor, blah, blah, blah. This is circulatory dysfunction. Shock, for me, is when you have hypoperfusion. When you have hypoperfusion, then you should resuscitate. Sometimes. And for me, the big fallacy is to every patient that is a little bit hypotension, has a low vascular tone, that can be easily solved with small amounts of norepinephrine, for example, give fluids and fluids and fluids, and then what are you treating? Are you trying to get rid of the vasopressors? Or are you trying to restore tissue hypoperfusion? So for me, you have this distinction between acute circulatory dysfunction, vascular tone, hypovolemia, blah, 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 versus real shock. Real shock is hypoperfusion. And this you should focus on. I mean, this is the biggest mistake in my opinion.
Well, we look forward to your work and your attempts to try and answer and challenge that fallacy. It's the end of our 30 minutes. Like always, Glenn, it's been an absolute pleasure talking to you. I look forward to seeing you in Paris at the end of the year at our ESICM conference. Pleasure, Glenn. Take care now and have a good day. Thanks everyone for listening in.
Thank you very much.